Hello there. Hello and welcome to tonight's MHTV. We're doing things a little differently tonight because Dave's on the move, but be assured you have tuned into the right thing. It's us. Tonight we're going to be talking about mental health nursing's identity, and I think it's going to be a really interesting discussion. We were going to have Emma Jones with us, who's not here tonight, so I hope you're feeling better soon, Emma. And we do have Vanessa with us, but she's not on camera at the moment, so she'll be contacting via the usual means. But if you want to join in on social media, let me hand you over to Dave, and Dave can tell you how you can do that tonight.
Hello from a very lovely Bristol at the moment. As always, it's great to join in and see all the people out there that are going to be joining in tonight. You've got a couple of options to do that. The first is on the Facebook live feed. All you need to do is head over to the side. There should be a little place for writing any messages, comments, questions, any bits of interest that you want to share about tonight's topic. The other option that you've got is over on Twitter. All you need to do is either reply to the tweets that I'll be sending out or to use the hashtag MHTV. We'll be keeping an eye out for that hashtag tonight. And obviously we'll be able to bring in any of the stuff that's relevant to the conversation. But without further ado, straight back to you, Nicky.
Yeah, absolutely. Let's introduce our guests. So we have Chris and Michael with us. So Chris, would you like to tell us a little bit about yourself?
Yeah, so my name's Chris. I'm a lecturer at the University of Central Lancashire. My kind of interests are in sort of conceptual problems within mental health. So my background is kind of philosophy and thinking about some of the things that we might get right and some of the things that we might get wrong in mental health. My professional background is working with children and young people, really, both in kind of long-term psychological work and crisis management of young people. Hand over to Mike.
Yeah.
Thank you. So my name is Michael Haslam. I'm a senior lecturer and a PhD student at the University of Central Lancashire. So I'm very interested in, because my background's crisis care, mental health liaison. So I'm very interested in things like crisis care and how this is experienced. I'm very interested in the barriers and the facilitators to that. But within my role as a mental health nurse lecturer, I'm very interested as well in the barriers and facilitators in terms of nurse education.
So for people who aren't quite sure what we're talking about, we have a governing body in nursing called the Nursing Midwifery Council. It's not the RCN, close your ears, Dave, who are a trades union of sorts. It's really important for us to understand actually how our profession is shaped by these professional standards, because obviously people write the professional standards. Hello, Vanessa. And then those standards dictate the kind of education that nurses get, and that again shapes the way the next generation of nurses think about themselves. So, you know, we had these new standards, they came through in 2018. So anyone who's on a BSc course or will have just had that first 3-year cycle. So we're getting the first set of nurses qualifying, or just qualifying through, from those new standards. And there's been a lot of debate. Shall I say that? Is that fair to say?
Yeah.
About these standards, particularly from areas of nursing who are smaller in number. So I think learning disability nursing struggling to get its voice heard of any kind, but certainly mental health nursing and children and young people's nursing have voiced serious concerns about the type of priorities that are being put forward in these standards. So this is not a new debate, but it is an important one for us to have. And I wonder if our guests could comment on that. What do you think the impact of the NMC standards has been?
Perhaps I should go first. Is that okay, Mike? Yeah, is that okay?
Absolutely.
Just as you mentioned then, Nicky, that how mental health student nurses see themselves is it sort of like just kind of sprung a thought to me about a separate thought about their identity within themselves as a student nurse becoming into qualifying, and it's a great thought, really. In terms of answering your question about the change, there's been a seismic shift, really, or so we've argued in our paper, and that's that seismic shift as we argue has been to move towards a generic standards, a broad base of nursing, which has its advantages. We can see that that there are some advantages to kind of genericism and generic nursing. But when it comes to mental health nurses themselves and what we do, how we hold to our true identities and our unique identities in mental health nursing, the kind of seismic shift that I'm kind of alluding to is that it's a dilution. The move towards genericism and kind of broadening the base of nursing is reducing that specialism. And as we argue, I think we argue in the right way, weakening the profession.
So what do you mean by genericism? I mean, I know, but I'm just asking. Don't worry.
Yeah. This has been a really difficult thing to actually capture. And if you give me kind of a bit of space to map this out. So there are a couple of arguments that around genericism, what that might look like. So as we argue in the paper, it's an adult-centric nursing education, in that the skills, the things that are prioritized that all nurses must know and mental health nurses must know have been shifted from specific mental health nursingness. So that could be how we use the law, how we adopt the way we use ethics, how we navigate values in really difficult situations, has been supplanted by proficiencies, procedures, physical things that are done to people. Now, we might think that is kind of adult nursing in some respects, because a lot of what adult nursing is working with somebody and doing something to them in order to make them feel better. Whereas there's a philosophical shift which has moved us closer towards that type of nursing, as opposed to being with someone and actually experiencing distress with someone, as what we argue in the paper. So genericism is a broad basis of nurse education that is diluting specific skills of mental health nurse education that we feel very strongly that service users need from their registrants.
Is there anything you wanted to add to that, Michael?
I think in terms of genericism, it feels like we just sort of invented this term genericism, because when I'm looking back at it, I can't sort of actually work out where we got the term from. But genericism is more around, so we'll look at, there's two things in my opinion. First of all, there's the genericism in terms of a generic set of standards that underpin the curriculum that we are delivering. And then I suppose there is this move towards a generic nursing role as well as a result of that. So we're in terms of, when we talk about genericism, I suppose we're referring both to the curriculum and the standards that underpin that curriculum, and then genericism in the respects as well of our sort of mental health. Chris talked about a dilution of mental health skills. So this move towards a generic nursing role, it feels very much like nurse education is being inevitably moved towards a generic nursing role, or at least that was, when we've had discussions around that, that's very much what it feels like.
Yeah. Is there anything you wanted to add to that, Vanessa?
Yeah, no, I was just reflecting whether you think that it reflects a wider genericism in nursing overall. I work mostly in the prisons, where it's probably more integrated than anywhere else, in the sense of the whole healthcare team being there and being present, which has, lots of great advantages around, holistic care. But I just feel that maybe nursing, mental health nursing overall, is becoming more generic in the way people are seeing it. And I just wonder if some of that as well is about, like, it's really hard to articulate sometimes what we do, because a lot of what we do is, as you say, relational. It's tied up with, legal and ethical considerations and moral dilemmas and that kind of thing. So yeah, I'm just interested in your thoughts on that, really, whether it reflects a wider genericism and why that is.
I think there are a couple of things happening. So we have this term genericism, which I think we probably did, as Michael, to kind of make up to try and as a word to capture the phenomena. It might actually be a disingenuous word, in the respect that if we think about genericism across nursing, across the four fields that we have, you might think of education or the standards representing that sort of equally. So we maybe have 25% adult nursing, 25% mental health, and the same for your paediatric and learning disabilities. A colleague of mine, Dan Warrender, what he argues is that genericism's veiled, and it's veiled by adult centricness. So this kind of that there's a shift towards moving us towards more adult focused, particularly in acute settings. And we track this back to within the article to the all the way back to Francis, really. If we look at kind of the Francis reports and subsequent reports that followed, all the way up to the Willis reviews, what we find are crises across nursing, but particularly in kind of acute setting hospitals, with a lack of skills. And there's a real clear theme from those publications, which was skilling, reskilling, and upskilling. And this skilling has been translated into procedures, which we think is the wrong thing to do. There are different ways to think about skills. And somewhere as we've moved from this notion of improving physical healthcare, it seems to have infiltrated the standards, so much so that it's then been infiltrated to the HEIs, where we're now left with this kind of broad skilling of people. The consequence of that is in my view, that we leave people with a skill set who are leaving universities, which one, they're finding difficult to get done actually in their nurse education, particularly in the practice document, which hopefully we'll talk about a little bit later. But also once they get into practice, that those skills that are being delivered may not actually suit their roles that they're moving into in that kind of contemporary mental health nurse service, and so what gets replaced is the relational, as you describe it. So we talk about three themes in the paper. We talk about genuine advocacy, which is a concept about being genuine to someone, but advocating for someone in the right way. Therapeutic use of self, and sort of in that relationship, in that dyad with that patient, which is tacitly known for mental health nurses. We all see what we do well. But what we don't, but what is difficult for others to see is actually what's going on in that kind of interlocutor.
I think certainly, I mean, no one's denying, the idea of the Willis report, etc. Talked about the need for us to be upskilled, and I suppose there's something in that. The counter argument to this is, well, actually, there needs to be a parity of esteem in regard to physical healthcare. But what we're saying is we're not denying that there needs to be a parity of esteem in relation to physical healthcare from a mental health point of view when we're looking after mentally unwell people. What we're saying is it's down to the type of skills that are needed and the extent to which those skills are needed. So I know Chris and I had a bit of a discussion earlier today, and we talked about this idea of students chasing skills. And that's essentially what they're doing. They're chasing skills rather than doing actual mental health nursing within their nurse education. So we're prioritizing, for instance, things, proficiencies such as cannulation, venipuncture, catheterization. Now, we're not saying that there aren't going to be extended roles within mental health nursing that are going to require those, but it seems like they are defunct skills for most mental health roles at this moment in time. And also there's something, I suppose, as well around the idea that when we're ticking these boxes, it means that the students are not learning those relational skills that we need to learn by actually spending time with the patients.
Yeah, I agree.
I think there's a couple of things.
Sorry, go on.
I think there's a couple of things that feed into what you're saying. I think one of them is this move to more kind of quantifiable pressures in society. So it's easy to teach I know, I suppose that skills teachers are about to agree with me, but it's easier to teach cannulation, isn't it? And everyone gets shown cannulation, everyone does something on an arm, and then you tick it that everybody knows it. Whereas teaching the kind of relational experiences and how to sit with distress, that stuff's so much more intangible. And I would say as well, some of this is that we haven't historically been great at saying mental health nursing is special, it's different, and here is our skill set. And frankly, when it comes to palliative esteem, you guys need to skill up about how you talk to people about suicidal ideation, how you talk to people about self-injury when they come to your A&E departments or emergency departments. You know, I think we haven't been forceful enough about our own. We've been too diffident about mental health nursing. That'd be my say.
I think it misses a point as well, even reducing the physical health down to a procedure in a kind of reductionist way. So, for example, if you think about someone who is protesting by not eating in prisons or drinking, it's not just the physical health component, is it? There are all sorts of complex sort of psychological dynamics going on around why a person isn't eating. There are all kinds of issues around capacity, you know, around risk and safety. So it's kind of seeing that, yes, as mental health nurses, of course, we need to contribute more to the physical health agenda. But what we bring is more than just being able to do procedures. It's about being able to look at the kind of bigger picture around, you know, the individual person and the reasons why maybe they're behaving in a particular way, and you know, like you say, working therapeutically with somebody to help them kind of through those challenges. And I think that's
So what's missing then from these standards, and what's different about mental health? Let's get into it.
That's a question that I think is going to take a discussion of our workforce. That I don't think I can adequately give you an answer that says, you know, this package that I'm going to give to you now is what is missing. I don't think I've got those skills. Perhaps in this room now here, we don't have those skills to do that. And that was I think the real beauty of our article really is that we hopefully have set that kind of academic discourse off. You know, what we wanted to do is ask the question is what is it to be a good mental health nurse? What does that look like? And we talked about three concepts that were really important to us. One of the things that I'd like to get in is that there are a few names on the paper, but actually the paper actually belongs, I think, to the team at UCLan, because that came out of so many very good conversations. There were times when I was shouted at by my colleagues who were perhaps more senior than I am because of my perhaps naive view of mental health nursing and lack of experience as compared to my colleagues. And so what's missing is a really difficult question to answer, and one I want to pose to people who are out there online at the minute, and ask, you know, what are we missing? What do we need to do? Vanessa, you're talking about physical health. That must be in there within those standards, within the NMC curriculum. I think that the fact that there are so many service users who experience disproportionate sickness and morbidity as per the rest of the population, that's a problem we need to resolve as mental health nurses. But the uniqueness, the special thing that we do, the thing that wasn't captured by the NMC that we point to in our article, it are things like what happens within that dyad, what happens within that interlocutor, how do mental health nurses recognise good mental health care when we see it, but yet it's not known for other people around, and that's what we're alluding to. One final point on this, actually, an interesting point, and I wonder what your thoughts are, Nicky, in that there's been, I think what the standards have done is kind of make divisions within the fields. Actually, it's kind of, I think what the standards were trying to do, or one of the things that the standards were trying to do, was to bring the profession closer together, and that we would recognise ourselves as registered nurses first. Actually, I think that what has happened, and I've received lots of correspondence from paediatric nurses who said that they feel disconnected from the standards. I know mental health nurses feel disconnected. In fact, we have a movement, Mental Health Deserves Better, which is building on that disconnection. And one of the things that has been proposed is that we kind of move away from nursing altogether, and that we align ourselves more with a mental health profession. I'm a nurse. I don't feel like that. I feel very proud of my nursing status. But one thing I'd like to see what the group think is, should we move away in a similar way to what the midwives did and have our own education setting, because there is something very different about mental health nursing that we need to capture? Can it be captured in just kind of generic standards?
I think you're making a lot of really interesting points there. And I guess one of the reasons this has happened is because we didn't have a strong enough voice in ourselves. But also I don't know that these standards particularly serve adult nursing, because they make adult nursing so task orientated. They undermine a lot of the philosophy models and thinking that the family of nursing has done. And it's become very much tick boxing instead of something which is creative and thoughtful and has a psychospiritual kind of vibe to it as well. So this is why I don't get asked to write things, because I put vibe in things. But what I will say, whilst we've been talking and we've been wondering if anyone else is listening, the questions have gone off the charts. So we're going to have to take a break to come to the questions. So Dave, can we come over to you? Because you guys have set people off. Well done.
I've got a quite hard task tonight, so it's whether I'm going to read through all of these that have come in so far, and maybe you pick the ones that you feel are the easiest to answer and sort of answer some of them and pretend the others aren't happening. So Jane, as well as liking, I think a daughter likes your hair, Nicky.
Thank you.
She's made a few comments and she's kind of answered a few. So one of the things that she's put, which is probably quite a big global question, is mental health nursing education part of the solution or the problem? And I think that fits in quite nicely in terms of maybe one of the arguments the NMC would push back on this is, well, we've given you kind of like a loose framework. It's now up to you, amazing academics, to go and create the mental health nurses of tomorrow. And if a bad job is done, it's actually you guys that have done the bad job, not the kind of the standard setting NMC. So have you got any kind of thoughts on that pushback?
Perhaps I could answer the second one. I don't know, Mike, is that all right with you?
Yeah, you go for it. I'll tell you what, you go for it first, Chris. Go on.
So the get out of jail free card that we set at sort of ambiguous standards that can be interpreted by the HCIs. Absolutely, that is it's a very good question and an apt observation. I can't let them get away with that in some way, because the role of the NMC is not only to protect the public, and that must be their first priority, but they do also validate our courses, and there must be, or I would hope there is, some framework or process that allows for that validation to have a consistency across the 4 nations. From the group that I sit in, what is clear and evident to me is a drive towards this genericism that has been validated by the NMC. So there are consistencies within universities up and down the country with delivering that pre-reg education that is delivering this agenda. And I'll give you another example is when we originally submitted this article to our first journal, they rejected it outright, which is, you have to get used to it. You have to get used to the rejection. But the reason why I mentioned that is because they said there was no evidence that this was a nursing NMC problem, and that it was just the HEI that you were registered in. And I can absolutely, with my whole heart, say to you that this is a 4 nations problem. There are representatives across the 4 nations that we are all saying the same thing, that we have shifted. There is a philosophical fundamental shift from what I would describe as principles within mental health nursing that are not being applied in the standards. And so that get out of jail free card that I can provide ambiguous principles that you must now follow and interpret, it just doesn't stack up for me.
I think I'm going to come in there, Chris, if you don't mind. Sorry. Yeah, I agree. Absolutely agree with you. You know, the NMC, sorry, the NMC essentially left it to the HIs to interpret those and to operationalize those through the practice assessment documents, etc. But I'm in full agreement there. There should have been some sort of procedure in terms of validation that ensured that operationalization, I can't say the word now, across all across all HEIs was done, so that actually a mental health nursing degree in London is the same as a mental health nursing degree in Preston. And at the minute you can't say that because there's different interpretations of those standards. Some have more content than others. Yeah, absolutely. The other thing is I just want to sort of bring in as well, cast our eyes over to Australia, where we saw genericism sort of sneaking in the 80s, and that's left the mental health system in Australia with real problems, because you have people who don't even hold the title of mental health nurse, that they're able to call themselves a mental health nurse without actually any formal training. And that's left real issues in terms of identity and in terms of being able to care for more complex individuals working across more complex environments as well. So we need to be careful that the standards allow us to, allow the HEIs to be able to interpret them in such a way that we don't move towards a generic role. And yeah, I just wanted to sort of point out Australia they're about 2 decades ahead of us, and they're having some major issues over there, aren't they?
They're unhappy. They're unhappy. Hurley, Malloy, Lakeman, they all write in this area about the impacts that's had on service users in Australia, increased seclusion rates. And
I used to work in Australia, and I have to say, I have to agree, because there's nothing. What I found really dispiriting was when a nurse, like an adult nurse, can't get a job in adult, they'll come and work in mental health.
Okay.
And it made me fuming the whole time, because they're just not, it's just different kind of characters work better with different populations in different settings. And it kind of makes us a poor relation, and that's a real issue. And when you're talking about how the standards are written, if you have a very strong, organized senior team who are from adult backgrounds, which is not surprising because most nurses are of adult background, because that's the numbers. That shapes everything, because you can have really sort of talented mental health nurses and children's nurses who are able to articulate their practice, but if they're not the person setting the meetings, that's automatically undercutting that voice. I suppose we better come back to Dave for some more questions.
Yeah, it's interesting as you talk about this, because it kind of sort of reminds me of the conversations we had when we were arguing against the shape of caring that Health Education England produced, and the kind of, the anxieties and MHNAUK put in a response to that, where we kind of highlighted the concerns of our members and how it could be kind of, moving down the Australian model that our members were saying they certainly didn't want to go down that route. I said I was going to read all the questions out, and then I've failed to do that. I've only read one of them, so I might try and speed up a little bit. Now, Shoshana, she says she completely agrees. Now, the danger is she could have completely agreed with anything over the last 30 minutes now, so you kind of got to guess what she's completely agreed with. But she's carried on and said, I am currently a student lead on an acute mental health ward, and the proficiencies largely base around skills that students do not have the opportunity to complete in MH settings, e.g. catheterization, blood transfusions. Students also explain how they feel underprepared qualifying in mental health settings, as the proficiencies are not being based on skills they feel they need, including de-escalation skills, teaching coping mechanisms, mental health act and legislations. So I don't know if you just want to completely agree with that, or sort of contradict, or...
Yeah, I think she put that really well.
Absolutely, I agree. So there were a couple of things that are points I'd just like to kind of capture there. One is this proficiency chasing, where if I put myself in the shoes of a student or Shoshana, as you said, goes out into practice, goes onto a ward, and realizes that perhaps 50, 60, 70% of the things that she needs to do in order to pass and get through to the next part of the program, whatever part of the program that they're in, are very difficult to obtain within the practice setting. Now, if that was on a community, that those would be impossible. And so this proficiency chasing idea that now it's more important, and perhaps rightly so, more important for the student to go and chase these and go and find out, make lots of phone calls, who can help me to be able to pass the course. And what that then does is it impacts on the learning of what it is to do the actual job in practice, and what it is to do that well. And if we're engaging in that, or if students are engaging in that, and then coming back into the university, and we're hopefully wanting to engage in, so how did it go? And now we've got our complaints about chasing these proficiencies within that PAR document, something that really does need to change. Then the learning is minimized, and there is so much more that can be done. But this again goes back to shape of caring. Those proficiencies that they're chasing were recommended by Lord Willis, which of course the NMC took up in their standards.
Yeah.
So we've then got
Why are we
Jane.
letting people who are not nurses tell us what nursing is?
I know.
Sorry, Dave.
It's okay.
Exactly.
So Jane Fisher also said, as a service user, genuine advocacy is of vital importance and value. And then Reese has replied to that saying, do you think this should be a competency?
Wow, that's two wonderful comments, actually. So genuine advocacy is something that we've coined within this first paper. What we've got coming in the future, so we've got a paper under construction at the moment and two more in mind. And these are to flesh out these concepts of what these actually are. So to go to the philosophical underpinnings. So my hope is that every module across the UK will take the name of genuine advocacy as we set it out to be, as being an absolute fundamental underpinning of mental health nursing. And so it should be more than a proficiency; it should be a module in every HEI's institution. And I hope they all say, "Oh yeah, Chris Connell did that with his team." That'd be wonderful.
Now, Mike Ramsey, a friend of MHNA and on our editorial board, I know he wrote quite a seminal paper previously on a similar subject. Is there an argument that we dilute all fields achieving sense of graduateness in nursing education by the chase for skills and procedure lists? Julie then says, do we think students realise while still on the course all the skills they are potentially missing out on? And I wonder if perhaps it doesn't hit them until they qualify.
It's a really good point. Yeah.
Third year.
Sorry, Chris, go on.
No, go back.
No, I was going to say that we tend to hear nursing students, not within our institution, but wider than that as well, on social media, for instance, who talk about, since the paper's come out, said, we get to the third year and that's when we feel really, really unprepared. We don't really know what skills we actually need until we actually get to that point. I suppose it's like anything, don't you? If this is normal to you, this is the way that you've been trained, you don't know what you're missing out on. We know what people potentially missing out on because we've had a different type of training. But you were certainly getting students who are coming to the point of qualification and going, I genuinely feel that I need a longer period or further training in a particular area. They don't have, for instance, when we talk about things like formulation, they don't seem to have the same underpinning knowledge anymore around things like attachment theory, psychodynamic theory, the things that were standard to us. And we used to do whole modules on psychosocial therapies, and they're sort of really squashed down now into a matter of weeks and even days under the new curriculum, just because there's so much other stuff to get in there.
Yeah, I would agree with that. Just speaking from a practice point of view, we've got 50 health and justice sites around the country, so a lot of sites. And we've put all our mental health staff through clinical assessment training for exactly the reason you say, that when we did the sort of baseline audit, it was surprising, like many nurses who don't have the clinical assessment skills that you think they have, and don't have that kind of underpinning around attachment theory and, you know, sort of the relational kind of stuff. And, you know, the feedback, you know, from the training's been phenomenal, really, you know, in terms of people saying it's the best the best training they've had, kind of thing, because people recognise that that was really missing. And I think with the new training, there's more, it places more responsibility really on the employers. So we're having to think about, particularly in health and justice, which is quite specialist, about what skills our mental health nurses need within that setting, because it's quite an autonomous setting. And, you know, in terms of things like preceptorships and which kind of prisons people might want to work in post-qualifying, obviously thinking around things like a remand prison, you know, thinking about comparing that maybe to an acute ward, that maybe that's not the best place for somebody to start out if they feel like they're lacking certain skills. And I think it's moved the whole focus, and as well, the ECP course and the ACP course, we're having quite a lot of influence in being able to say, these are the modules that our mental health nurses need in health and justice. So we actually need to shape up these courses to make sure they fit with what our workforce needs. So, yeah.
I think there was an impact of workforce planning on these standards originally, when people who were employers thought, if I can get someone who can do everything, that'll be really handy. And you're like, well, yes, but if you're paying somebody who's a qualified nurse to do things you can pay somebody much less to do, then you're kind of
you
undermining your own, well, you're messing stuff up basically, because you can't have one person to do everything because they've only got one pair of hands. So you can certainly train someone to be able to do everything, but if they don't do, I mean, I've never ever put a catheter in anybody in 30 years.
I haven't.
Public or private. I just think, well, I
wouldn't want to either.
I mean, I'd give it a go.
There's some mention earlier, sorry, of education. But I would argue that this is exactly what it is. It's moved from education to training. We are a production line process now. We are producing the workforce, and that's quite sad, really. Students, you know, students are missing out on so much in terms of their knowledge, you know, that could underpin the relational working and all of that. And we're working with people with complex trauma. We're working with people, and we need to have that underpinning knowledge, because if we don't, we're doing them a disservice. And I wanted to get in there. Sorry, Chris. It was one of the things I wanted to just get in before we finished. It's not just about mental health nurses, you know, getting really cross and waving placards and things like that, which we talked about. You know, at the end of the day, we're talking about how do we improve outcomes for our service users. Okay, ultimately, it's about sort of how the standards have moved us as mental health nurses away from being the sort of mental health nurses that service users actually need. And that's one of the key things that make us angry.
So Jane Fisher said one size doesn't fit all when it comes to mental health service users, which is absolutely right. And Shahana said she's been seeing a trend in new preceptors requesting more extended time because the initial supernumerary period comes to an end, and of course people are feeling that they're underskilled and underprepared, so it's having this knock-on effect. So I think we are heading towards the end of this, as Michael pointed out. So let's think about what's happening now and what action can we take. So what's the next steps with this?
Good question. I think that almost as a segue from what Mike was saying about not preparing the workforce for service users. So one thing our article does argue, and I think argues rightly, is that it is the service user that holds that unique position in services, so that we need to meet them where they are. We need to meet their needs to engage with them, and that's a really important point. If we start from that position, we can start to think about, well, what are we not doing now? What is it that we're missing, and what actions do we need to take? And I think that we need to rethink the standards. Essentially, we need to rethink, and I know that's a huge legislative change, and I know that means an awful lot of work. But if I had my magic wand, if to use a solution-focused approach, if I had my way with what I would do, is due consideration needs to be given to mental health nursing and its uniqueness and what it does as we meet the service user, what the good mental health nurse does as they meet the service user in that time of distress. If we start from that point, we can start to unpack. At the moment, the current direction of travel, particularly from the HAE, is to provide a flexible, generic workforce that can move from one ward to the other. That might not be maybe as skilled as what previous generations have been within that fundamental mental health nursingness that we've been describing. And so we need to counter that. We need to change or work with the NMC. Our paper calls on the NMC to move towards understanding that this generic process won't work, and the education should be given specifically on the lines of critical thinking and what it is to make good decisions in conflicting and pressurized environments, navigating values, navigating the conflicting values, real ethical dilemmas that mental health nurses face, with very much the sole focus on kind of emancipation from mental health services and promoting that kind of notion of autonomy, that kind of helping service users get to that point where they can live in the world well.
Yeah. I would say, as Chris said, that's that without sort of there being huge legislative changes, that would be the ideal, really. But I suppose in the short term, it's about sort of gathering the support of our relevant stakeholders. So gathering the support of student nurses, you know, it's their education, they're paying for it, they're consumers. It's gathering the support of the service users or service, you know, survivors that we're working alongside, we're working with in solidarity with people, sort of looking, you know, working with the NMC, working with individual HEIs in order to critically examine what we currently provide and how we can make that better, how we can make nurse education, mental health nurse education better for our service users ultimately. And I suppose that's the starting point for us all. There are grassroots. There is a grassroots movement, as Chris said. You know, mental health deserves better. You know, it's a hashtag on Twitter, and that's the very sort of beginning of that. We're coming together. We're sort of developing a bit of a manifesto and writing together and sort of hoping to lobby people just to say, you know, this isn't right. This is what we need. Our service users are the people who demand this of us. It's not just about us as a profession. It's in conjunction with those people who we're supposed to be caring for and who demand that distinct presence of mental health nursing on the nursing register in the first place.
We've got another message coming in from a student, CYP student. Hello, Erica. Lovely to have you with us. It feels like we've got a lot to learn from mental health nursing. Well, that's a lovely thing to say. I think we've got a lot to learn from each other. And one of those things I think is about recognizing our individual skill bases and where we overlap and how we're different. And thank you very much for your comment. I guess we need to start thinking about finishing up now. So has anyone got a final thought? We'll come to each person, a final thought or an action people can take. So we'll be retweeting out the articles if anyone wants to dig into that and understand some of the arguments that we haven't had a chance to get around to. Also, Michael's mentioned the hashtag for mental health deserves better. So please feel free to join in and understand a little bit more reading up on that. But Chris and Michael, is there anything that you want to leave people with?
One final thought for me really is, you know, we've talked a lot about mental health nurses, adult nurses, CYP nurses, learning disability nurse, and there is no one is better than the other. It's almost like measuring apples and oranges, I would say. And the question I would like, or the kind of thoughts I would like to leave us with is that, you know, if I do go into a physical health hospital and I go in there, I want to be seen by somebody who is expert in that field, doing that job, who loves that job. And it's the same in a mental health hospital. If I take my kids to a children and young persons ward, all those things, that's what I expect from healthcare. And if we don't have that, if we do have somebody who is trained 25% mental health and so on, are we still capturing that same expertise in that field as they graduate from pre-reg education? And that's just the final thought from me. And essentially, that's what we're arguing for: is not to have that.
And my final thought, I suppose, is, you know, we talked about the validation process in terms of the NMC. We talked about the HEIs. I suppose one thing we haven't really discussed is actually, I think you've touched upon it already, but as mental health nurses, you know, we must take some of the blame as well, because we've been not very good in terms of articulating what it is exactly that we do. As we said, it's very implicit what we do. It's known within our own service, it's known within the role that we do. Our service users understand what we do. It's almost like some sort of implicit thing between our service users and ourselves as mental health nurses in terms of outcomes, etc. But to the outsider, it's not explicitly known. And I suppose we as mental health nurses need to be more vocal and need to be more explicit about what it is that we do, and you know, try and hopefully our paper is sort of the beginning of that discourse, trying to articulate who, you know, what it is exactly that mental health nurses do, and we should be proud of what we do as well.
Vanessa?
Yeah, it's hard to distill it into one final comment, really. But I think a lot of what has been said, I agree with. And I think for me, every conversation you have kind of in the wider world comes back to what mental health nurses need to be more skilled in physical health. You still hear that. And I think it's like what Chris said actually in his comments, that we're not saying that we don't want to be skilled in physical health. Of course, we need to be skilled in physical health, but it's also about recognising what mental health nurses do. And we want mental health nurses to look after people with mental health difficulties who, of course, have holistic skills, including physical health skills, but the recognition that they also offer something unique as a mental health nurse. And I think the takeaway for me is really what I'm already doing, to try and encourage, you know, mental health nurses to have a voice and to kind of articulate what they do, and, you know, to get involved in these conversations. So, yeah, that's it for me. It's been really interesting tonight.
Yeah, it's gone fast. Dave?
I suppose I'd like to finish with a really kind of positive message in terms of, you know, I think it's great that, you know, Chris, Dan, others have sort of vocalised the concerns, obviously the stuff Michael shared tonight. But there is kind of ways to get this addressed, not just in terms of having these really good conversations amongst the profession or amongst people involved in mental health and mental health nursing. You know, at Unite, we meet on a regular basis with the NMC and kind of saying to them that, you know, there are these concerns that the profession is raising that need to be addressed. And, you know, there's two ways of dealing with it, really. There's the fingers in their ears and pretending that everything's fine, or there's engaging with the conversation and trying to come to some kind of understanding of you know, how we could kind of improve this. Obviously, you know, we're hopefully helping to, you know, make that happen. But also, you know, MHNAUK, the academics group, has done a lot, you know, through, you know, the membership of, you know, people in this virtual room. But also in, you know, people that have gone before. And I know when the NMC were kind of discussing the standards, MHNAUK put a lot of effort into having that voice as the voices of the profession. And I suppose, you know, hopefully that will carry on and act as a vehicle to kind of to sort of, you know, build up and respond. And when you think at the recent MHNAUK conference, you know, the Chief Nurse Health Education England was there and, you know, had that dialogue with people in the room. So it's really positive, isn't it, that that's happened. So just to kind of, you know, give that extra bit of, you know, sort of positive, and not because, you know, of the work that you've done that's been so valuable. So, you know, well done, guys. Keep it going.
Okay, so I guess that boils down to, if you love something, fight for it. And next week, what we're going to be talking about is, we've got Cleanser Jarrett Hall with us, and we'll be talking about fair pay for NHS workers, and I guess we'll be mentioning the word strike. So brace yourselves. But thank you very much for you guys for joining in with such a sort of passion and interest. It's really exciting to have these conversations. So much appreciated, and see you next week. Take care.
Thank you.
Thank you all.
Bye-bye.
Thank you.
Bye.
Bye now.